Okay. I think we're ready to go. Is that right, Liz? All right, Adrian. Okay, well, I want to thank everybody for rejoining us here. We're starting now session 5, lung cancer and COPD imaging, technical imaging guidance. The panel we're about to start is called Improving CT Lung Cancer Screening Through Image Quality Optimization. We're very fortunate to have Dr. Sean Fain from the Functional Lung Imaging Laboratory at Iowa Institute of Biomedical Imaging at University of Iowa, and Dr. Stephen Lamb from the British Columbia Cancer Agency and the Pan-Canadian Lung Cancer Screening Network, which of course is in Canada. Dr. Mario Silva was supposed to be with us, but he unfortunately had something come up and couldn't make it, but he's going to present some slides pre-recorded, and he's from the University of Parma in Italy. So what I'd like to do, I should also mention Raul San Jose Estepar is my co-moderator here for this session and for the next session as well. So what the next step is for my presentation to be played, and then we'll give, actually we'll go into the panelists and have them present their views. So if you'll play my video, that would be great. Today, I'll be talking about improving CT lung cancer screening through calibration phantom and software innovations. So as we all know, early detection of lung cancer is absolutely critical for survival. The 5-year survival rate jumps up significantly if we detect things as small as 5 millimeters or 6 millimeters. But in order to be able to do that, we need to CT image 6 millimeter or 5 millimeter objects, like these solid lung nodules you see here. And a really small change in diameter or volume can result in a big volumetric change. So it's really important that we get the imaging right. We're working with very few pixels, and it's important that we get the imaging right and highly calibrated so that these diameter measurements or volume measurements are done with high precision. And for that, we need to consider that the quality of a CT image degrades significantly in some scanners as you go out from the center of the scanner. So the center of the scanner is going to be generally the highest quality. And as you go 50, 100 millimeter, 200 millimeters out from isocenter, you get worse and worse quality on some scanners. For example, here, this is a machine on the left where you're going to see a nice thin slice. This is looks like a slice from a loaf of bread. But on another scanner, if you ask for similar performance, you might get this kind of basically bowed out shape, and it's not a normal looking slice at all. So your results can vary quite a bit depending on what scanner and what protocol you're actually using. Now, we've been documenting over the last 15 years large numbers of issues in CT scanners, including biases in Hounsfield units, the density numbers from CT scanners, as well as spatial warping and many other things. The biggest thing we saw was that we saw spatial warping on the order of 44% when we put phantoms on the chest of patients. These spheres should not have changed in size at all, yet we saw changes of 44% on the same model at different locations. And we've seen this clinically. This is time 1 on the left. It's time 2 from Mount Sinai. They got a case with this type of scanner, and and you can see that this was referred for biopsy, but it turns out that this is not growth of a nodule from this time point to this time point. This is actually just spatial warping of a CT scan due to the scanner itself. So fortunately, this was caught and the biopsy wasn't done because that would have been unnecessary. Now, we've built phantoms like table phantoms and other things where we put them in these types of scanners, and we see the spatial warping gets worse as you go out to the periphery. And we've even gone as far, because people don't believe us, despite how much we say it, gone as far as measuring this out to the periphery. And the blue dots are on this 16 slice scanner using a helical acquisition mode, which is really the only mode you can use when you're doing a breath hold scan. And then the orange dots are when you use step and shoot. So you can see the tightness of the samples, the volume measurements when you use step and shoot versus when you use helical scanning. And this represents a 33% change in volume of these 6 millimeter by 6 millimeter diameter and height cylinders that you see here. So we definitely have a major problem here with this type of scanner, and it really shouldn't be used for lung cancer screening, especially for large patients. But I think the more troubling thing here is that we first reported this in 2011 in a major clinical trial, and it took over 3 years to publish these results, resulting in a JMI 2016 paper. And then I've made numerous presentations every year for the last 10 years. Yet even today, FDA approves these model scanners for lung cancer screening. AAPM provides screening protocols for these scanners, as you can see on the right. There's no mention of these scanners as having issues in numerous lung cancer screening guidelines, and numerous medical physicists continue to deny that spatial warping exists in 16 slice scanners, as we've been reporting. So basically, after 10 years of studying and reporting on this, it's really long past time for the community to accept that this major problem happened and that global image quality monitoring needs to be updated and running continuously, so image quality lapses of this magnitude never happen again. That's the hope, right? Now, the way we solve this at the company I run, Acumetra, and in conjunction with the RSNA and KIBA, Quantitative Imaging Biomarkers Alliance, is we've developed a low-cost phantom that can measure fundamental properties of the acquisition system from the center of the scanner out to the periphery. And we build a 3D mathematical model based on this information, a mathematical model of the acquisition system. And it's all automated. You just scan the phantom, upload it to us, and you get back a report within 5 minutes. We build that 3D model using what we call, this is a little technical, but a Gaussian point spread function. This is a mathematical way of representing resolution. And once we have that information, we can experiment and build any images of what objects would look like in a scanner where we have that resolution information plus other things. And we produce visualizations like this to show what it would look like if you went on a future generation scanner with a certain object versus you went to the absolute limit of what our requirements suggest. So we've done lots of supporting studies on this. We have a recent study that just completed showing very high quality, indicating that we have very high quality, but there are no accepted standards that we can compare against for measuring 3D resolution. This is just a major, major problem. And we've also shown over time, these methods, when scanned every 3 months for over a year and a half here, are very stable and really quite remarkable in terms of their stability. Now we have 115 CTLX1 and CTLX2 phantoms distributed around the world, thanks to the Prevent Cancer Foundation grants and their grants. And numerous countries and organizations are now adopting this. So we've got a global network in place right now, which is awesome, running on the cloud. We've got the FDA, medical physicists at the NIH. We've got Stephen Lamb and his group putting out recommendations to use these tools, and we're delighted with the adoption around the world. We have a new phantom that better supports radiation dose versus image quality studies. And you can see here, it's a water fillable phantom with these things that look like hydration packs. This one's packed here with those water packs. And we can insert objects in it that look like simulated objects that look like nodules into the phantom, and people can check their software with it, the volumetric software, and make sure it's high quality as well. We put out some COVID-19 CT imaging guidance based on all the work we've done and the scans that we've analyzed over the years. We've actually analyzed over 1,400 CT scans from around the world. And because of that, we can now put out recommendations on which recon kernels work better for lung imaging, as you see here for COVID-19. We're working now, and Chuck Hatt will talk about this in his intro to the next panel, how we're coming up with a new guidance that will combine lung cancer screening and COPD, and we'll give guidance on how to acquire images for both those major diseases. Now, what can we do with quality information once you use these phantoms? Well, first thing is we can, in the future, provide precision follow-up times, where if we know the baseline diameter of the nodule, and we know the precision of the measurement instrument, the scanner and the protocol, we can look at how much time would be needed for different volume doubling times, as you see here. And 90 days might still have too much overlap, so we might set it to be 120 or 150. Again, one of the things you can do once you understand the precision of your measurement system. Another thing we can do is look at the trade-off between radiation dose and resolution. And here you can see on top a scanner that as you lower radiation dose significantly, the resolution stays the same, but the noise goes up. That's what you normally expect. But on another scanner, if you do the same kind of thing, the resolution is lost, but the noise stays more stable. Well, that's radically different behavior that sites don't know about unless they have a phantom and can do image quality checks and radiation dose checks as they modify protocols for different size patients. We also have ways of measuring the software of systems by inserting these small ellipsoids inside of phantoms. And we've seen some issues in different commercially available software in terms of the biases and the precision of those measurements. Another thing we can do is if a site has two different model scanners and they want to know, can they scan a patient on one at time one and on the other at time two, we can look at the image quality metrics that we have and align them better. So here there's different scanners colored in gray, orange, and blue. And you can see they're quite a bit different in resolution. But if we were to modify those protocols and bring them closer, both in resolution and on the right with noise, we might be able to lift the restriction that the patient has to be scanned on the same machine each time. That's a major limitation. It's a real problem for clinical sites. And with these tools, you can do that. And then more imaging reconstruction on CT scanners is more and more using AI. And that's going to create a lot different, a lot of potential differences in how reconstruction basically modifies those images. Not every innovation, though, is going to be for the better, just as we saw with those 16-slice scanners back 10 years ago. So we need a global image quality safety net, as we have now, to make sure that the quality of these images, as these new innovations come in, stays high. So in summary, we have now a global network of using a new low-cost CT calibration phantom, the CTLX-1 and the CTLX-2. We have 115 phantoms distributed around the world, and those sites can now quickly verify their CT image quality. And not only that, but they can optimize and they can share their crowdsourced protocols for CT lung cancer screening. And again, Chuck will talk about an effort that I'll be inviting a whole bunch of people to soon to look at guidance on protocols for both lung cancer screening and COPD. Now, it's important to recognize that these types of phantoms produce 3D mathematical models, and those models then can be used to predict performance for different clinical applications. But the more exciting thing to talk about here for this panel is going to be the potential clinical uses of CT image quality information, such as setting more precise lung cancer screening at follow-up times, not doing better nodule volume growth or doubling time estimation, and also putting error bounds on those estimations, optimizing both radiation dose and CT image quality for nodule detection and measurement, enabling sites to use different but calibrated CT scanners and protocols for follow-up scans, establishing and updating image acquisition recommendations in real time with massive amounts of data like you see with this network that we have. And then finally, maintaining a global safety net for catching issues when scanner vendors deploy new CT innovations like artificial intelligence, and there'll undoubtedly be many, many other innovations coming. Finally, it's really important that we recognize that there are no accepted methods for measuring CT resolution. And thus, even though we have a study right now that is indicating our CTX1 data is both accurate and reproducible, we are having difficulty proving it because there is no gold standard. So if I could leave you with one thing at the end of this talk, is the absolute critical importance of establishing a worldwide 3D CT resolution standard so that clinical sites can verify that the scanners they've purchased achieve those results that the manufacturer provides, and studies and research can document the quality of their scans, at least in terms of 3D resolution. So that's the story. Thank you very much. I appreciate your time. Okay. So that was my presentation. Next, we're going to hear from Mario Silva at the University of Parma. Can we play Mario's?
Good afternoon, everyone. Good afternoon, colleagues. First of all, I'd like to thank Rick Avila and Raul San Jose for the invitation and the session, and I hope you will all accept my apologies for not being present at the discussion. In this presentation, this brief presentation, I'll be discussing about the point of view of a clinician reading through lung cancer screening images while using software. So there is a kind of a balance here between the visual quality and the quantitative quality that we aim to. To start rapidly with that, image quality is indeed conditioned by both slice thickness and reconstruction algorithm. And when we use different reconstruction algorithms, we might be aware that if we apply iterative reconstruction and we apply progressively increasing strength, we might have a gradual drop in the recall, so in the number of CAD candidates for detection, while increasing the precision, so reducing the false negatives. At the same time, this is probably not true for all the softwares on the ground. And in this example from this table, I'd like to show you the example of a scanner with 3 different reconstruction kernel, B30, B60, and B80. Probably B30 is something that you might want to use with software. Otherwise, B60 and also B80, quite sharp though, are those that you're going to use for visual reading. So if you use 4 different softwares across these 3 kernels, you'll see quite heterogeneous behavior of the software, and this meaning that the kernel and the softness of the kernel is actually influencing the ratio of false positive per scan. This is shown here in this graph as well, where the system A and the system C behave differently across the 3 kernels. B30, very low number of false positives for software A, whereas software C shows a higher number of false positives with the kernel B30, and the opposite with the B60 and B80 on each side. Another interesting thing here is that as you decrease the dose to the patient, So the image quality, the signal to noise ratio might decay. Actually, some software shows quite a steep increase in the number of false positives. So image quality is something that you want to have under your eye when you use software and low dosity for lung cancer screening. So the reconstruction algorithm is also very important for the segmentation. We see here the volume with 3 different reconstruction kernel, the filter back projection, the iDose, and the IMR. And we see how the volume of the structure is actually changing according to the 3 different softwares. So how should we behave here? Well, the answer might be in the pockets of the QIW group, the small lung nodule, where there is a substantial strive towards the standardization of the quality data. So probably when you use low dosity for lung cancer screening, you want to have your data certified for quality. And this is something that I've tried. I was lucky enough to be able to try with the CTLX-1 Phantom distributed through the QIW group. And I tried it across quite a number of kernels. These are standard kernels on my scanner, the scanner I use for lung cancer screening. These are different features for the definition of the standard of quality at 3 different points. As you can see here, for software kernels, the data quality is pretty high. But of course, when you take a look at these images and you evaluate those visually, it might be not as good as you want to have. These are actually the kernels that you want to have when you use when you read visually the images. And as you can see, this is mainly the main box of kernels that you might be using for reconstructing low dosity for visual reading. What about algorithm to read these images? Well, you have a bunch of further kernels that might help you. And so here's the choice that we applied in Parma for our lung cancer screening project, which is called PIPO, with this small typo here, because it's actually for having this typed in Google and having just our program in your search bar. So for our screening program, we decided to have a double set of reconstructed images, a BR49 and an SA36. The SA36, as you can see, is perfect for quantitative images, and the BR49 is going to give you the extra quality for visual reading. So this will be the setting of reading that we have in our lung cancer screening clinic. And you will have a reconstruction for visual reading parenchyma, a reconstruction for quantitative reading parenchyma, and a reconstruction for visual and quantitative reading of mediastinum, and in particular for calcification. This one is quite thick slice, a 3 millimeter one. And you can see that this also allows a quite good reading of the mediastinal structures, despite the DLP is very low, I would say below the 20. So how's the reading at our place? You see a nodule, or the CAD detects a nodule, and you scroll through the nodule visually as it's shown here in the video. So you scroll the images, they're paralleled on the screen. The left-hand side, you will find the BR48 or 49, depending on the scanner that we are using in Parma. And on the right-hand side, you will find a quantitative reconstruction. This contemporary review will allow both visual detection and quantitative detection. And indeed, once the software has detected the nodule, you can easily scroll through the nodule. And while you have the visual evaluation of the segmentation, you will also have the visual evaluation of that thing being actually a real nodule and not something like mucus plug or different things that actually require quite a spatial detail to read through. This was my personal point of view on quantitative data for lung cancer screening via CT. This is a substantial and mandatory step forward to standardization of the practice of lung cancer screening. And meanwhile, it might be not always appreciated by radiologists reading low-dose CT. And indeed, low-dose CT with visual reading standards is also needed for confirmation of the lung CAD marks and for reviewing other features such as interstitial lung abnormalities and further small findings such as bronchial thickening or emphysema or other parenchymal details. I hope again this was an opportunity to give you some point for discussion. Of course, a drawback of the proposed reconstruction and reading method is that the volume of storage is going to be a bit larger than compared to a single reconstruction. But probably at this point, this might be an option for merging both visual and quantitative reading. And thank you for your attention.
Okay, well, now that we heard from Mario, we'd like to move on to Sean Fain. Sean, do you have some words you want to say?
Yeah, sure. I don't have slides, but thank you very much for inviting me to offer my thoughts. I want to emphasize from the overviews that we've really entered an era of quantitation that I think is challenging conventional views of medical physics, in that the scanner performance and harmonization is, there's much higher demand on these factors. And I think the role of phantoms and phantoms that can be shipped to multiple sites is a real advantage for the field, in that it enables us to understand just how much variability there is out in the installed base when we're trying to do quantitative measurements, as we are in lung cancer screening with nodule detection and measurement. I think another couple of things to point out is, I think the standardization of kernels that Mario just discussed is a really critical issue and has only gotten worse, and I think is emphasized by quantitation as well. And I think it would be, and has been an issue for several years, helpful if we could identify a subset of kernels across vendors that would perform similarly. I mean, we've done that experimentally, but to have kernels that would be designed for quantitation would be useful. I think the other point to make is, as my role in QIW has evolved, I was chair of the lung density biomarker committee, and we designed the profile for the lung density measurements around an effort to also measure high resolution in the airways of the lungs. And I think that has sort of naturally led to a significant degree of overlap with the challenges that are faced by lung nodule measurements and volumetry measurements, and opens the door to quantitation of multiple parameters in these CT images that are being acquired for lung cancer screening. I think that's a topic that will be discussed at the next session, but I just wanted to point out that as we move forward with Kiva and development of profiles that are standardized towards quantitation, it opens the door to multi-parametric measures. And then I guess the last thing I wanted to emphasize was the role of IR, and then I guess in addition to that, I guess as we move toward multi-parametric measures, AI and machine learning. So all of those are on the horizon and will only increase the demand on harmonization. So I think there's two schools of thought maybe out there that somehow the developments in machine learning and AI will somehow resolve the variability that's out there. But I think, as we know, in terms of how AI operates, especially the deep learning algorithms, they will only benefit from harmonization and improved consistency of image acquisition. One comment I guess I'll make as a side, which might stimulate some discussion, is that I'll push back a little bit on Rick's comment about there being no 3D resolution standard. I think the CAT fan is capable of that. It's just very defined in an in-plane versus axial mode. And so as a consequence, does not naturally lend itself to a fully 3D resolution measurement in a simple way. And with that, I'll pause. That the presentations were excellent, and those are my thoughts.
Well, thank you, Sean. I'll just comment that every scanner vendor sends out their own Phantom for their scanners. So there's no accepted, I think is the point. There's no accepted 3D, 2D or 3D resolution standard. And I'm not the only one to say that. IAEA also has said that, but we can discuss that a little later. Dr. Stephen Lamb, you have some slides, right?
Yeah. So good morning. Thank you for inviting me to take part in the panel discussion. I would like to give a pulmonologist perspective as to why it is so important to be able to measure, not make measurements accurately, consistently, and also stable over a period of time. Can I have my first slide, please? So next slide, please. So I just want to give an example of a part solid nodule at baseline and 3 months later. As we can see, that the changes, especially in the mean diameter, is very subtle. But if we be able to measure the volume of the whole nodule, especially the solid core separately, we can see the nodule actually have a significant growth with a short volume doubling time. And when we resected the tumor, and it turned out to be a 1A2 adenocarcinoma. Next slide, please. So I think we'll be seeing more of these subsolid nodules over time. This is just showing the trend of lung cancer, both in terms of the lung cancer deaths and the proportion of lung cancer deaths in relation to the smoking status. So the red line is where we are in 2021. We already have more former smokers, people who have smoked previously compared to people who are still smoking. But in the next 20 to 30 years, we'll see more people who have never smoked with lung cancer compared to people who are still actively smoking. Next slide, please. So this is a provocative study from Taiwan, the talent screening study, where they screen never smokers with a family history of lung cancer and some other risk factors. If you look at the baseline screen, even if we take away the adenocarcinoma in situ, the invasive lung cancer rate is 2.1%, which is higher than NLST or Nelson. I think more importantly, almost 80% of these lung nodules are subsolid nodules, which is the reverse of what we see in ever smokers. And then there's also a higher frequency of multiple primary lung cancers. Usually these are first appeared as ground glass nodules. And these lung cancers have a different etiology. And for example, I think ambient air pollution plays a significant role. Next slide, please. So we all talk about personalized screening. We want to look at the risk-based management of lung nodules. We want to personalize the screening interval to reduce unnecessary screens and reduce missed cancers. But to develop this deep learning algorithm, we need to consider the effect of different exposures and genetics, and people who never smoked versus people who have ever smoked. They need different background. I think our challenge is to how to look at a normal appearing lung and see who would actually develop an interval cancer that do not actually have a nodule on a prior scan. And I think this points to the importance of having a consistency, image acquisition and measurement, as well as stability of image quality over time that are critical, especially for subsolid nodules in terms of volume and density measurements. And we have to follow these nodules for a much longer period of time compared to solid nodules. So I think I would like to stop here.
All right. Thank you, Stephen, and thank you, Sean. And I guess we have to send a thanks to Mario as well. But now we're at a point where we can start to get into some of the questions and some of the issues that have been raised. So I'd like to just start off with the lack of a 3D resolution standard in CT. We met as a technical breakout group yesterday, and we reviewed some of the facts associated with that, which I didn't get a chance to put in my presentation here, but I just want to add to the statement that I made earlier that there is no accepted phantom used by all the scanner vendors. There is no accepted phantom used by all the sites around the world. And then thirdly, there is no accepted software methods for measuring an MTF. There is at least 6 or 7 places where you could make a different decision, whether to do smoothing, what type of smoothing, et cetera, when you're calculating an MTF. And again, there is no standard for how to do that, calculate that MTF. So while I don't want to say there is no standard, we're left with the reality that if there is if there is no accepted standard from the vendors, if there is no accepted standard internationally, as the IAEA makes very clear, and if the software even of analyzing a phantom is not standardized at all, as far as I can tell, there are documents out there. They do give some information, and it is somewhat helpful, but it is not specific enough, like we do in Kiba, to cut down the variability in the measurement. In this case, it would be the 3D resolution measurement. So I don't know, Sean, do you have a reference for a 3D resolution standard that I can point to and learn from?
I don't disagree with the point you make about there being no standard phantom. I think that's probably true. What I meant was to emphasize that there are long-standing approaches like the line response function, the point response function, line pairs, etc., for evaluating both axial and in-plane resolution that the vendors have used to evaluate performance. Now, I know the vendors have, there's ways in which you can make systems look better than, weight towards the better performance, but and measuring the full width half max and the full width 10th max, and there's many other points where analysis of the resolution has some subjective elements. And so I'm all for coming up with, as a field, an accepted way to do this. But I just wanted to push back a little in that, there are accepted linear system approaches, right? And I just felt I needed to say that.
I agree. I agree with the sentiment. I don't know, Raul, do you have any comments on this?
No, I echo, I think, Sean's point that I think there are elements, and I agree with you that probably what we are lacking is a standardized way of reporting resolution. That I think, to me, is kind of maybe a narrower but even very critical element. There are methods to assess resolution that probably, as you said, diverge in intent and is critical details, but that will be always the case. It's always, for even all the algorithms we work with, there is different ways to assess nodule volume, there's different ways. So I think it's hard to maybe, quote unquote, standardize that, because it's the essence of how you approach, but what you can standardize, I think, and it's very relevant, how you report that. And if you will, you could even qualify those methods or define sort of a guideline document to say how you qualify an approach that reports under this criteria. And it's true, I think we are lacking a way to say, if I develop a method or I replicate a method, how I go about knowing that is measuring resolution in a precise manner. And I think, to me, that is, I think you bring an important point. Maybe my focus will be in focusing. I think there are methods. What we are lacking is how those methods are reported for what we consider are the critical parameters, as well as how then those methods are qualified. I think there is a huge lack of that qualification, that I guess those, in my opinion, go hand in hand with the lack of phantoms in that domain. And maybe, and that is my last thought here, then what we lack is how then we make this sort of combo of software with metrics go into the clinical practice. How then resolution becomes a critical piece of the quality loop, in both at the in the medical physics kind of workflow, as well as maybe eventually even in the day-to-day operations. So I think, to me, addressing that is probably a gap where that has not been addressed yet. And I think there is where I think a group like this could make a big impact.
Yeah, that's a great point, Raul. This kind of feeds into what I was mentioning before about having standardized quantitative kernels, because then if you had that and it was accepted across vendors, then you wouldn't have this competition necessarily about my scanner has higher resolution than your scanner. And if it's all based on a standardized kernel directed at similar performance across all systems, then that's the goal, right? It's not about the other key features of your system that you can use to sell it, etc.
Well, actually, the approach that we've taken is that we try to bring every scanner to its highest performance that we can find. We're not trying to make sure that the best scanner achieves the median, let's say, resolution, for example. So, I think ultimately we want to leverage the best resolution you can get out of every scanner, among other image quality properties. So let's take a
well, can I push back on that too, Rick? Sorry.
Yeah. No, please go ahead.
The reality, you can say that, and it sounds great, but the reality is, and maybe I'm speaking a little bit from my own research perspective on airways and density analysis, right? So in that setting, we're really not actually using all of the resolution that is available to us. In most cases, we're using a standard kernel, which standard on the GE side, but a smooth kernel on, across vendors. that enables us to do robust segmentation and measurement, right? Because it's a complex structure and that sort of challenge, as well as mitigate some of the noise that would otherwise contaminate histogram-based analyses in parenchyma. So I just find it a little bit interesting. I mean, I think the obviously nodule detection and measuring the volume, et cetera, is a much more, I don't know, it's a very demanding problem. The airways are too. So I guess I push back a little on that, whether we necessarily want to always push for the highest resolution, and maybe it's consistency of performance that could be an important factor as well.
I wouldn't say you pushed back at all, because the standard kernel is the highest resolution kernel we can get out of most GE systems without edge enhancement.
Yeah.
And so we're not interested in the appearance of high resolution where it isn't, which is what edge enhancement does in plane. We're interested in the highest resolution the scanner can produce without edge enhancement. So
that's actually not true exactly. The standard kernel is quite smoothing, so there is more resolution there.
But again, if you can provide a kernel on, let's say, a VCT, a Lightspeed VCT that has higher resolution than the standard kernel, but does not have edge enhancement aiding it, then we'd love to hear about it.
But before I give, Dr. Yankelevich wants to make probably a really insightful and relevant comment, but before we go into that, I think just one thought is that, and related to the topic of this panel, is that I think the beauty of having these quality control approaches, around resolution, density, and so on, indeed, is to me around the fact of finding the minimum common denominator. That harmonization has been our killer here, and I agree with Sean that we narrow down in maybe non-suboptimal reconstructions, because we know that it gives us sort of the common minimum denominator we need to do everything we need. Probably, obviously, to me, is very different to be, what happens in nodule assessment, where basically you have a measurement available to you of a very small object, versus what happens in airway assessment, where at least, lucky enough for us, we can do many measurements, and somehow use the power of statistics to come up with a metric of airway disease. So those are obviously differences, very important differences, that I think this is why I think some of the issues you brought up, Rick, around wrapping had been less kind of effective. We had been more naive about it, because maybe we were being blindsided by the power of statistics. But my point is that we need to definitely come up with a strategy about how to use the beautiful quality metrics you report, Rick, in a constructed fashion. And I think, to me, this is where we are lacking a little bit. Either for protocol specification, that I agree with you, the AAPM maybe didn't use this panel to truly say this is what we think is I think they use experience, but they use less of a quantitative approach to define the list of scanners and protocols they propose. So then I stop there, Dr. Yankelevich.
Thank you. I have a few comments to make. Our group were actually the ones that started doing volumetrics. We brought that and we licensed it to General Electric. This is over 20 years ago. And back then it was Stan Fox. I don't know how many of you remember Stan. Wonderful guy at GE. And we said to him, it could even be better if you improved certain things on the scanner. We really could do so much better. And he just said to me, unless you can show that there's some, clinical demand for this, forget it. We're not going to invest anymore. It's good enough. That was kind of his approach. And now in this session, you just heard from Stephen. We need to do better now. We really need this if we're going to measure things accurately. And I think the clinical demand is finally catching up now with pushing the scan developers and the people that are sort of the overseers of all of this to measure things better. CT is really now moving into the quantitative domain, where it's not just producing the pictures, but we need to measure things, and we need to measure small things. And so I think now what's happening is we need to catch up on the standardization side. We recognize we can measure things volumetrically. This is really powerful stuff. This is going to guide CT screening. The ability to measure nodules accurately is going to be the key to doing it really well. And the idea that we don't have a good 3D measurement of resolution, it's stunning, really. I mean, I saw that thing from the IAEA, you showed it to me, Rick, where they basically said there's no standard for measuring 3D resolution. That's amazing because we're all doing it. And the field is marching down that path aggressively now. So I think the idea that Sean said that this is a great place to make a statement or to bring this point out, I think this is fantastic. It really needs to happen if we're going to drive this forward.
Great. Okay, so why don't we pivot now over to what other things we can do with the CT image quality information. Dr. Lamb, have you thought about the most promising applications of image quality data?
To me, the challenge is how you identify people with interval cancers. So the ones that have a prior normal scan and then they have a new nodule of a cancer appear in between screening interval. So those usually are higher stage or small cell lung cancer. I think being able to quantitate what appears to be normal in the lung is crucial to improve our success in detecting and treating these cancers.
Agreed. Any comments from others?
I have a question and follow up on that. Do you think it's important to have other information too? I was just curious, as we discuss efforts to develop multi-parametric approaches, is it relevant in terms of your clinical interpretation to evaluate things like emphysema in addition to lung nodule measurements?
Well, right now we do kind of a semi-quantitative type of measurement for emphysema. I mean, we discussed in the earlier session, it may be useful in certain ways, but we have to recognize the U.S. Preventive Services Task Force recommend against COPD screening. So we need to produce the evidence that by detecting emphysema early, we can actually reverse or stop the progression of the disease. So the data is not there. We need to have the data to show that by detecting something, we can actually alter the clinical course of the disease. So lots of these incidental findings are useful. Lung fibrosis, but again, you're talking about treating the patient with very expensive anti-fibrotic drugs. Then we have to show that by doing that, we can change the outcome in a cost-effective manner.
Great. Thank you.
We have a question from Jim Mulshine.
Yeah, I think it's been a great panel, important topics. And Steve, a couple of people have mentioned before, the U.S. Preventive Services Task Force has not recommended COPD screening. I think that is standalone COPD screening. I don't think they've really commented on the fact that in lung cancer screening, you get an image that allows you to do COPD screening without incurring the cost of establishing, independent COPD. And so I think that's a different issue. And I think that's not yet proven whether it's cost effective or not, because it really doesn't add much cost to the fact that you already have the scan and you have the radiologist looking at it. And we'll have to find out what the incremental workflow effort is. And we'll have to demonstrate that's of utility. And we'll have to validate that COPD interpretation reflects the biology of COPD and not measurement artifact or the other stuff we've been discussing. So I mention that because I don't think you have to be constrained. I think that there's a public health sensibility to CT screening the lung for cancer relative to COPD evaluation and coronary calcium evaluation that really is brand new, that hasn't been evaluated by U.S. Preventive Services Task Force. And we may not want them to do it right now, but it is evolving. And I think we should not be constrained by that statement. I'll stop there.
Yeah, I think calcium score in the coronary artery may be more straightforward, but I think scoring emphysema, I think we do need to have some more evidence to support that by intervention will change the clinical outcome. Maybe looking at airways may be more productive in terms of intervention. Because we can also control symptoms and prevent hospital admission for COPD exacerbation. So those are better defined endpoints, but to say that we can take a pill or inhaler or whatever, we can reverse the emphysema or stop the progression. I don't think we have the evidence for the radiology to suggest that we can do something, take action about the finding.
Steve, I'm sorry. What I'm saying is what has been said before, and that is, if you just know that someone has COPD and they're still smoking cigarettes, I think that sets up a conversation about the enhanced significance of that finding relative to the cost to that individual that is smoking. So I'm not saying that you can cure emphysema, but I think there's some preventive strategies and stuff like that, like smoking cessation that we've been discussing, that could be more relevant if you found out all of a sudden that you're one of those 75% of the 20% of people who have, potentially significant COPD found the same time as your lung cancer nodule assessment. And it turns out that it's moderate to severe. You might be very amenable to lifestyle modifications and smoking cessation. And that's useful, and it doesn't cost that much. And that may be the basis for this kind of analysis along the lines of the bar that Ella Casaroni's been discussing in terms of being clinically meaningful.
Yeah, I think just to add to what Jim's saying, I think that the quantitation really enables some new things that haven't been explored before. And so I think instead of, it sort of turns it on its head in that you definitely don't have the data yet, right? But the availability of quantitative measurements in a multi-parametric analysis allows for the exploration of associations, right? That could reach clinical valuable endpoints. And for example, I don't know, COPD could be a predictor of poorer cancer outcomes. It probably is. And exacerbations could be linked as well. And so that might help guide approaches, and maybe it does already. I'm naive to some of that perhaps, but that might guide the way you would treat the individual patient, right? That's kind of how I'm thinking about it.
Okay, we have just a couple of minutes, so 1 minute left. I'll try and squeeze one more thing in here, and that is Mario brought up the fact that he's reconstructing two recon kernels for each scan. And we've also got now scanners that can do 1024 by 1024 matrix size. So we're potentially talking about, if the site were to leverage that, we're talking about 8 times more data. and I've heard it said before that some places require that radiologists view every pixel. Dr. Lamb, any thoughts on getting the best quality images with 1024 by 1024 matrix size overlap and then multiple reconstructions?
I think it's a great research tool to have, yeah.
So long as the radiologists read it, he's saying.
Okay, I think we're at the end of our time limit. At this point,
Rick?
What's that? Yes.
Rick, I just bring this, Ella Casaroni discussed this the other day. This is a big issue. there is going to be a growing discrepancy between the images that are preserved for clinical assessment versus the images that might be desirable for quantitative assessment. And there is a, systems have some rules about everything being reviewed by radiologists. And Ella was suggesting that we could do a service to the community by saying that they are different, and we have precedents with other imaging things where we have a different data set for analysis and a different data set for clinical review. And if we could bring that forward, we could allow the research component of this to be studied through time and not burden clinical radiologists with undue workflow restrictions.
Agreed. And the satellite, analysts who look at satellite images have gone through this already. They've long ago had exceeded their ability to review every image, and they require computers to help them. So, yeah, if we put together some, let's say, statement regarding the need for there being this type of multiple acquisitions for different purposes, that would be good. So at this point, I think we're at a lunch break, unless somebody tells me otherwise. And we resume at 1:15, right? I believe that's the case. So, all right. So I guess we'll see you all at 1:15.
Okay, so welcome everyone. I think we are heading into the last part of this session file with a panel to talk or discuss about the needs or establishing a technical guidance for a combined COPD and lung cancer image acquisition protocol. And I think we discussed a lot in the prior sessions about the clinical need, what are the potential issues and lack of data. I guess we hope in this panel to discuss maybe a little bit more of the technical challenges, and although we might not be fully ready from an implementation standpoint, might be worthwhile definitely kicking the ball on what this, the technical pieces of a combined protocol, and that how can enable future trials. So without further ado, I want to introduce our speakers and panelists, beginning with Dr. Charles Hadd. And so Chuck is a good friend and also Director of Research at InBio, and also adjunct professor in the Department of Radiology and the University of Michigan, and he's a leader in the development, validation, and application of quantitative imaging biomarkers. And then Chuck will have an introductory talk, and then we will have a panel that will be also composed of Dr. Ella Caseruni. It's our real pleasure to have her here with us. She is a professor of radiology and internal medicine at the University of Michigan, with a long-standing commitment to lung cancer screening research, coverage, and implementation. And Dr. Caseruni also serves as a vice chair of the National Comprehensive Cancer Network Lung Cancer Screening Panel. Then we also have Dr. Nicholas Patrick, is the Deputy Director of the Division of Imaging Diagnostics and Software Reliability of the FDA, and is a member of the FDA Senior Biomedical Research Service. Dr. Patrick is deeply involved in developing approaches to do a robust assessment of methods for quantitative imaging and medical machine learning, a really key topic now from the regulatory perspective, and very informative for our conversations. And finally, last but not least, we have Dr. Washko. Dr. Washko is Associate Professor of Medicine at Brigham and Women's Hospital, at Harvard Medical School, and also pulmonary physician at Brigham and Women's Hospital. And his career has been devoted to the development and translation of novel quantitative approaches to characterize the clinical determinants of chronic lung injury. And he's the co-PI of the ALA lung health cohort that we discussed this morning, as well as he leads multiple investigator-initiated studies. So without further delay, I want to check, lend you the stage, and you can take us from here. Or do we have a video?
Yeah, it's a recorded.
Yeah. Thank you.
Hi, I'm Chuck Hatt, Director of Research at Enbio Inc. I'm also affiliated with the Department of Radiology at Michigan, and I'm co-chair of the RSNA Kiva Lung Densitometry Committee. I'm going to be discussing the establishment of a technical guidance document for a single COPD and lung cancer image acquisition protocol. I'd like to first briefly discuss QIBA, which stands for Quantitative Imaging Biomarker Alliance. The mission of QIBA is to improve the value and practicality of quantitative imaging biomarkers by reducing variability across devices, sites, patients, and time. There are a number of committees that are organized by imaging modality, and each committee works towards the development of a profile document which outlines best practices and standards. Additionally, claims about the reproducibility of biomarkers are established, which is critical for understanding if a biomarker measurement represents true changes in disease or just noise. The Small Lung Nodule Committee is committed to understanding and improving how accurately true volume changes in lung nodules can be detected in lung cancer screening CT scans, which is important for early detection. The advent of lung cancer screening has also allowed for the potential for screening of other chronic diseases, in particular COPD, due to the strong overlap between COPD and lung cancer in smokers. The Lung Densitometry Committee works on establishing claims and standards for lung density measurements, which have historically been used to quantify emphysema and gas trapping phenotypes of COPD. In spring 2020, the Small Lung Nodule and Lung Densitometry Committees got together to write a guidance document on optimal protocols for quantitative assessment of COVID. Not much was known yet about imaging QCT for COVID. We knew that CT imaging was not commonly used in the US due to concerns about contamination and the availability of PCR testing. It was also known that COVID patients often had severe airspace disease and alterations in pulmonary vasculature, but it was not yet clear the best way to measure the extent and severity of disease, nor how well the biomarkers predicted outcomes. The recommendations in this document were for the most part based on the deep experience of the QIBA committee members in quantitative imaging of lung cancer and COPD. One of the first studies to investigate quantitative CT for COVID was by Columbia et al. Out of Italy, where CT was utilized during the first wave of the pandemic. This study defined well-aerated lung as the percentage of lungs with pixel values between -950 and -700 Hounsfield units, and showed that a lower percentage of well-aerated lung was associated with ICU admittance and death. An important aspect of this study was that optimal protocols for quantitative imaging were used, and a detailed CT protocol was outlined in the publication. Inspired by that study, we were able to replicate similar results in a completely different cohort using a slightly different HU threshold corresponding to more severe airspace disease. This was in contrast to many other studies on the use of imaging for diagnosis and severity assessment of COVID, most of which were published under the guise of AI. A review article in Nature Machine Intelligence looked at 2,212 studies utilizing AI for image-based COVID assessment and found that not a single study in their search produced an algorithm that was ready for clinical deployment. A common reason for this was poor quality data sets, which often lacked the metadata or standardization or were biased. An editorial in Radiology titled Artificial Intelligence of COVID-19 Imaging, a hammer in search of a nail, pointed out that it's time to move beyond studies showing that AI can detect opacities at CT or chest radiography. This is now well established. So in other words, hey, we can detect and quantify features on an image. So what do we do with that? What is the use case? Going back to the topic of also screening for COPD during lung cancer screening, what we learned from the process of writing a guidance document for COVID imaging can be applied to the document for combined lung cancer and COPD image-based quantification. We already know that undiagnosed COPD exists within the lung cancer screening cohort. I'd like to highlight this recent paper, which looked at radiologist assessment of emphysema in 52,726 subjects that were undergoing lung cancer screening from 2003 to 2016 as part of ILCAP. Emphysema was identified on 23.8% of these scans, 76.5% of which had no prior COPD diagnosis. Now we need to establish that quantitative assessment can be used to screen for COPD. To do this, we need to standardize how we measure emphysema quantitatively in a lung cancer screening setting, and we need concrete examples of how screening for COPD can add value to lung cancer screening programs. One example use case is to use quantitative imaging to aid in smoking cessation. We developed this report as part of a smoking cessation clinical trial in collaboration with the University of Michigan, University of Minnesota, and health partners. It is based on the health belief model for improving the likelihood of adopting a behavior, in this case, quitting smoking. In this personalized report, low-density areas on a patient's lungs, as detected using automated software, are displayed on the report, and their percent low attenuation area is compared to results from the NLST study. The benefits of quitting and a helpline are then displayed on the bottom of the page. So we had originally designed the report to include a personalized cancer risk assessment based on lung density measurements, gender, and age, but initial results did not reveal a strong association between quantitative lung density and lung cancer. We looked at the literature and found a meta-analysis that concluded that there was no significant relationship between lung density and lung cancer, even though it found a strong association between visually detected emphysema and lung cancer. This was a very surprising result. We hypothesized that protocol standardization was the reason for this. So we performed our own analysis and published this result last year, showing that indeed there actually is an association between quantitative assessment of lung density and lung cancer diagnosis in the NLST. But this relationship was only significant if we filtered out scans that were reconstructed with very sharp kernels or very large slice thicknesses. Additionally, we pre-processed these low-dose scans with a noise reduction filter that harmonized them to be more similar to standard dose scans. This was a follow-up paper that investigated the effect of moving to a low-dose protocol on lung density measurements. We found that median filtering, or using iterative reconstructions for low-dose scans, resulted in lung density measurements that were unbiased compared to the measurements using a standard dose technique. We also showed that the ability to predict the presence of obstructive disease or future exacerbations was not diminished when using a low-dose protocol. This study showed the importance of scan harmonization, as well as the non-inferiority of low-dose scans for COPD screening. Similar to our results in the NLST, another study also looked at image processing techniques for scan normalization in a lung cancer screening setting. In particular, they demonstrated that a kernel normalization technique combined with slice thickness normalization significantly improved the ability of quantitative lung density measurements to predict all-cause and lung cancer mortality in a lung cancer screening cohort. I now wanted to show a few examples of how similar COPD biomarkers are currently being used clinically. This study out of Stanford looked at how parametric response mapping, another lung densitometry method, could be used to aid in the diagnosis of bronchiolitis obliterans syndrome. They showed that visual reads of inspiratory and expiratory scans compared to just inspiratory scans improved the sensitivity, but decreased the specificity of BOS diagnosis. However, when also viewing the PRM 3D overlay showing emphysema and air trapping, which is shown in this figure, in addition to the CT scans, the best combination of sensitivity and specificity was achieved. They also showed that a quantitatively measured air trapping score greater than 28% was similar to CT visual reads in terms of area under the curve for BOS diagnosis. Here we have two similar reports from different vendors that show quantitative imaging metrics for patient qualification for bronchoscopic lung volume reduction procedures. During these procedures, one-way valves are implanted in airways that ventilate highly diseased regions of the lungs, which causes those regions to collapse, resulting in improved lung function and quality of life. However, patients who have homogeneous emphysema and/or incomplete pulmonary fissures tend to not respond to treatment. Because inclusion in the original clinical trial evaluating the valves required these conditions to be met, they are also required for the intervention to be conducted. The new biomarker here is the fissure completeness score, which has not been studied nearly as much as lung density for emphysema quantification. But because this automated biomarker is critical for these procedures to scale, it has been rapidly adopted. This is not without its own challenges related to protocol standardization. For example, Embio provides the software that is used for Olympus's Select CT report. At 124 different sites using this software, we continually have to monitor the CT protocol parameters that are being used, and we have counted 78 different preferred reconstruction kernels used prior to protocol correction. Many clinicians simply aren't aware that correct reconstruction parameters are important for quantitative imaging, but are receptive to changing protocols and being provided educational materials. Other sites cannot change their imaging protocols for bureaucratic reasons. Technical guidance documents are critical to remedying these issues. So before I end, I'd like to pose a few questions to the panelists. First, how can we accommodate radiologist preference and scanning parameters while maintaining standards for quantitative protocol requirements? What are the clinical application targets of a combined CT image acquisition protocol for COPD and lung cancer? What studies are going to be necessary to demonstrate effectiveness of a combined protocol? And how do we move beyond statistically significant associations between biomarkers and disease and demonstrate concrete examples of how the biomarkers can be used clinically? Do we have enough data to support the role and impact of doing expiratory imaging in lung cancer screening? And what is the best way to disseminate and achieve acceptance of such a document? Thank you.
Well, thank you, Chuck. It's a phenomenal presentation of all the current work and how then can go about it with those kind of thought-provoking questions. So I guess I don't know if you want to add anything else, Chuck, before we open this to the panel.
Yeah, no, nothing too much extra. I did, forget to mention in the talk, just also the idea of the importance of kind of really getting to standardize these things. I mean, from the point of view of retrospective studies, it becomes a real challenge when, a site, this happens with us a lot, some researcher will want to do some study and has this great data set. Then we find out, well, we're not really going to be able to do it because all these CT scans have completely different protocols that are being used, and it's just not going to work. So, I mean, that was just one other point I wanted to add on the importance of standardization. But yeah, I think, I'd open it up to the panelists at this point to comment.
So, well, maybe to give a little bit of context, I guess I think we have talked a lot, during these 2 days. I mean, I guess there is the issue about emphysema and the importance of it, and I don't want to focus on that, but it's only focusing on the fact that, based on the data that Chuck showed, that emphysema is definitely an interesting indicator for lung cancer risk, and how by proper harmonization we can pick up the signal that visually is there. That indeed highlights the importance of laying down at least the technical guidance. So even prospective studies can be done, as we were discussing, just to gather further evidence for potentially COPD screening, if that is where we want to go. So, maybe I address this to Ella or George, because I know you were kind of in the consumer camp. What is your reaction? I mean, when you see that, okay, if we do things carefully, we can harmonize things. So then, assuming we can put everything on a level field, is this modifying your thinking? Is this somehow modifying your approach? And then how will you, from there, what is the feedback you will give to a technical definition so we can then get those studies going?
Yeah, so I would say that if you think about some of the comments earlier, it still always comes back to what is the value what value does it bring to do this? Making the clinical justification. And if the clinical justification and the value is there, it's easier to have those discussions about doing things like updating practice parameters around CT acquisitions. The ACR maintains practice parameters for a long list of CTs, several different types for chest CT. And to modify them, it really requires a statement of value and understanding of what the impact is. What does the literature say on this, so that one could make the justification for saying, what, our lung cancer screening protocol recommendation now is 2.5 millimeter slice thickness with a statement in it that says, 1 to 1.5 millimeter is preferred, but it's not required. What would it take to make that jump? Is that jump technically necessary? I think it probably is. Our, at our place, our chest CT protocols, we've had nothing thicker than 1.25 millimeters over, almost the last decade. So you're going to have early adopters. And with a protocol like that, we can get a lot out of it for many things. We've got our lung cancer screening at low dose. We run an emphysema detection software from Bio. We measure lung volumes. So I'm a big believer that it can be done, but you have to provide information to practices to know that there's value in doing it. It impacts downstream treatment by early identification of disease, and you can drive it into practice parameters that they respect, usually coming from their professional societies.
So,
Thoughts, yeah.
yeah, I totally agree. Maybe I want to ask a question, and then I have some thoughts and follow to that question. But Chuck, you showed, I think, some very neat features from things that have been around since the 1980s, and thinking about densitometry to the co-registration of images for small airway disease to Fisher completeness. When we talk about standardization, does one standardization allow us everything, or do we have to standardize or tune to a specific feature? Because that's if you can get everything, well, that's a much easier proposition than saying, well, this is kind of the best thing we should do for this type of feature, and this is kind of the best thing we should do for that type of feature.
I think we can probably get a lot. I think this in a little bit was going back to the earlier session where, Rick and Sean were talking a little bit about, what's the best kernel for nodules versus density, right? I don't think there's going to be one protocol that's going to give you the best for everything, but they're probably, something like a standard kernel on GE or like a B45 for Siemens probably is going to be, in like 1 millimeter slice thickness is going to give you pretty good for at least lung density in nodules, right? I would probably say the same for airways and other things, although I know a little bit less about that. But I think one thing that we haven't maybe talked too much about is a separate piece of software that actually does some post-processing on the images so that they can be harmonized for each particular biomarker. I think you guys at Brigham in particular, Gonzalo has been working on that a lot. Rather than having to fit everything within a specific imaging protocol, maybe we pick the best protocol that throws away the least amount of high frequencies while also not having too many of them, and then we use post-processing software for each individual algorithm. That's something to consider as well, but obviously that's a lot more complexity. So
can you comment on, you got there's acquisition, there's reconstruction, there's post-processing of reconstruction, this kind of image overload phenomenon that radiology practices seem to feel. The comments that have been made earlier today about some practices say you have to look at every image on every reconstruction, which technically nowadays is not feasible when you're doing the different recons for different purposes. Where do those three components, acquisition, reconstruction, and post-processing of data to get to harmonization, all sit?
I would suspect that, well, right now, I mean, the reconstructions, that's going to be with the vendors, right? The scanner vendors. I don't see that changing, but, that is one of the nice things about the idea of using scan harmonization post-processing is that could be something that's packaged with your biomarker software. I mean, I think you want to keep the number of entities involved to a minimum probably for that reason. But I would suspect that would most likely, maybe it'll become more rapidly adopted and the vendors will start could start doing that too. But I think that will have to live with the software, the biomarker software companies.
If I could just comment real quick on George's question regarding whether a different protocol is needed for different applications. I think when you get back to the fundamentals of optics, of resolution, contrast, noise, sampling rate, signal processing, essentially, you'll find that most of the applications rely on very similar things. But if you get into certain applications, they might also need, let's say, lower noise or just some. So what I'm trying to say is I think there's a lot of overlap, but there are some differences between them, and we'll get into that when we start holding our monthly calls on the lung cancer and COPD imaging guidelines.
Okay,
The
and-
radiologist, that's the problem.
Well,
From
so
the
I wanna-
from the computer vision
Go
point of
back to
view, you
Yeah.
guys know what would be best. It's the radiologist that makes us do all the other things for the different clinical tasks. But from a computer point of view, you could easily harmonize. The radiologists that present the more challenging aspect here.
Well, if you want to talk way out there, you can bring the reconstruction all the way forward to the viewer.
Yes, and this is, I think, an interesting topic, maybe a question for Nick, no? Just to bring the regulatory aspect, because I agree that the issue is putting maybe this harmonized reconstruction in front of the radiologist. No, the software could do it all. You know, takes the images, preps the images as they think is better suited for the needs, and then spit out the result, being totally transparent to the clinician. But what will be the consequences from the regulatory perspective of doing that approach, of basically consuming derived secondary data that somehow is not ascertained by radiological review? Nick?
Yeah, there's no, I mean, let's talk about different types of regulations. From a device perspective, that's practice of medicine, has nothing really to do with us. As far as we would be concerned, if they read the images, it's a practice of medicine. It may be an insurance or other type of issue, but that's not really our issue as far as getting an approval. So I think that wouldn't be the biggest issue. I think going back to Ella's point, though, I mean, you have some fundamental factors. The acquisition is going to give you the fundamental information from it. The reconstruction is, again, in a process for how you're going to either visualize or put a structure together for quantitative, some sort of measurement tools and so forth. And so I think what David was saying, I agree with. You have a lot of variability in what people want to see visually, and to do for certain algorithms, the visualization for a human may not be the same as for the algorithm. So trying to figure out what trade-offs make sense if you want to do multiple tasks, and there'll always be some trade-offs. Some will be less optimal for X versus Y, but hopefully that trade-off isn't so large that you can't still utilize it for those functions. And so I think that'll be one of the keys, is what are the trade-offs that make sense. The post-processing, I think, is a really interesting. One thing AI can do is AI can take suboptimal acquisitions and still acquire quantitative information from them. It can do that because it knows that this is a signature for how these quantitative measurements work, which would be the ideal scenario, where even if you're looking at a suboptimal, that is a one-to-one relationship to the quantitative measurement. And if you know that that's true, which it probably isn't, but assuming it was, the AI in theory can pull those all out for you. So in some sense, you can take crappy acquisitions, and as long as you know a good signature, you can pull those back up and get quantitative measurements. Now, that's likely not going to work as well as you would hope, but it certainly has the potential to help you, actually, in the sense that you can live with more variability in the acquisitions and still get a reasonable quality quantitative measurement if you are using deep networks and other types of applications. If you're trying to make direct measurements on the images, of course, then all these variations tend to lead to larger variability. And so the question is, how much can you get back? It's not going to fix all the problems, but it can fix some of the problems. And so thinking about that post-processing, what you'd want it to do, may be actually a really good starting point for trying to minimize some of the variability or some of the biases in the measurements. So it's a way to mute some of the effects, not necessarily eliminate them overall.
So
I think
we can reconstruct with 1x1 matrix size, and AI will solve it all for us?
Well, I didn't say, like I said, I'm not going to solve every problem, but you can certainly do things that are suboptimal, and it can have a transformation that AI can invert, right? I mean, just like we could do all the quantitative measurements from the projection image, that would actually be the best place to be doing them from, right? But we do reconstruction because we like to visualize in 3D, but AI could work on all the projections. And if you worked in that space, you would probably do at least as good or better a job in quantitation if you really could figure out how to do it. So, I mean, these are all things that are possible, but just because you do a reconstruction doesn't necessarily mean you can't get quantitative measurements. That's, I guess, my main point. But
Nick,
as you said, you pay a penalty.
correct me if I'm wrong, though. There are no fully deep learning CT reconstruction algorithms. They all start with a form of reconstruction which we're familiar with, like Feldkamp or model-based iterative reconstruction, and then they add an AI, a deep learning element on top of it. So they're always starting with something that we have good mathematics for. You're muted. You're muted, Nick.
Nick, yeah, we cannot hear you.
I was just going to say that's true right now, but there are plenty of people working on direct reconstructions. There's no real reason why deep learning can't do the inverse problem. The question is going to be, what are the failure modes? There are a lot of questions about how it works and what it might be able to do. But right now we have post-processing on deep learning, but it likely will move into a reconstruction. They're certainly looking at it in MR and many different modalities as a way to be more efficient. Mostly not because it'll do a better job than an iterative reconstruction per se, but that it'll be a lot more efficient in doing that. You can do it much more quickly. So those, I believe, will be coming at some point. How long, I'm not sure.
Let me ask, because Nick, you bring a very thought-provoking here topic, that is, well, let's obviously let AIs have finagle the data even before you see the data. So let me ask Ella, will you trust if before I basically let you see the images, will you trust a metric on emphysema that I send you? And then from there, how you guide your reading. What will be, how that will work? Because here, I guess what we are discussing is a little bit the issues around the fact that David was saying, that the radiologist is in between always. And what comes first is critical. So I don't know, Ella, any thoughts?
So I like to say trust but verify. And I think one of the challenges with AI outside of things that are, say, operational, like finding a potential bleed on a head CT and moving it up the reading list so it gets read sooner. I think radiologists inherently want to be able to visually verify and understand that what it is being presented to them, as opposed to taking a number or some information for granted. I think that's a fundamental thing in the practice of radiology. We see it already in things, you get output on potential lung nodules and their borders and their shape and their volume doubling time. And, we've nicely been able to integrate the tool, get the nodules, get the list into our report to make that part smooth. But then you go through the nodules and say, but that's not really a nodule, and that's a scar, and that's a granuloma, and that's tree and bud, or whatever it is. So it's trust but verify, like the help, but need to, we are inherently a visual field. We look at images, we interpret them, and we pull them together towards diagnosis and differential diagnosis. We're not inherently like a lab test where a number spits out, a tube of blood goes in for processing and a number spits out. There's no visual. So it's inherent in our DNA as a specialty, trust but verify.
I think that is, to me, is one of the challenges here. When we talk about bringing quantitative imaging, that is, obviously you can do many things, or behind the scenes in quantitative imaging, there is a layer that obviously I can argue you cannot verify. Then you have to trust. So we have to create maybe, and that is the goal of the technical guidance. We need to create the trust space, where obviously by knowing that this is done with a protocol that it fulfills or follows some criteria, then you are confident with the measurements. So this brings me to what Mario was presenting in the prior panel, that is this sort of combined acquisition, because I think here is where we could get with a technical guidance. This combination of the recon for the visual review plus then the recon that somehow try to harmonize all the technical compromises that have to be done. What is the panel's perspective on that? Is this the direction in which we can move? Is the technical guidance somehow to say, okay, let's let AAPM give the guideline for maybe, or ACR for the radiologists, and then let's have a couple of approaches for the technical piece of this. So then we end up having 3 acquisitions that then they get percolated through the different systems. Is this where are we heading to?
Yeah, it's really interesting that ACR practice parameters do not get into great detail beyond the acquisition and basic recons. They really don't get into, say, in the chest CT parameter, what an ideal recons are for, lung nodules, emphysema, and so on. So I think we're a ways away from that. But practices have figured out, especially more cutting edge practices, of what they want to get out of the information. And we tolerate the fact that there's series upon series upon series upon series, and that a chest CT that could be 150 or 200 images is 10,000 images, because we value the data that comes out of it. So, and it kind of still gets back to that value proposition. What am I getting out of it for storing all these images and plugging in these automatic recons at the scanner? I mean, it's easier to do this. You can pre-build them in the scanner and they automatically get reconstructed the way you want them. They come across to packs. They take more storage, so there's RT pushback, but we don't actually get much pushback at all for storing zillions of reconstructions. And we see the value in it. So the other part of this is the, you don't need to look at every image phenomenon. And if you're doing reconstructions for quantification, it's really no different than, our sister specialty within radiology of nuclear medicine, where PET CTs and SPECT CT scanners have been reconstructing CT data for a very long time. And they're not obtained for diagnostic purposes. They're obtained for attenuation correction purposes. So while the readers might scan through them quickly, they're not there for diagnostic purposes. And you see in their reports, these CT images were not obtained for diagnostic purposes, kind of standard language. And if they happen to see something, okay, but they're not interpreting them specifically. In some places, they don't even add a statement like that. It's just a CT for attenuation correction only, period. So making that mindset change in diagnostic CT, that there's the images you look at and there's their images from the same data. You're not losing anything, you're not gaining anything. You're changing the nature of the data to enhance your analytic capability and your quantitative analysis. Making that mental mindset change, I think, is important.
Does the panel agree? Could this be a direction to go? I mean, basically having this label, this recon is not for clinical use, no. So then we are a little bit of free of the, some of the.
I wouldn't say you label them as not for clinical use, because they're generated on clinical data, but it's the way you approach the full data set and where you drill down. And you've got your primary interpretation images, you've got the same data reconstructed differently for quantification. You're not losing diagnostic capability. In other words, you're not going to miss anything if you don't look at those recons. That's the safety net that people need to feel.
Well, I mean, is this the kind of thing that could be useful in the technical guidance, just to show how it's being done now at the, the sites that are adopting this? Because I think that's the main challenge. Is it's some sites, it's fine. It's not a big deal to just do these extra scans. But like you said, other sites are, the radiologists are required to look at every single slice. So it could be something like having something in your series description, reconstruction for quantitative use, just help the adoption of that kind of workflow, and maybe give an example of how it's done at the sites that have figured that out, so that other sites who are they realize they're going to have to start moving in this direction, and it could help them understand the way to go about doing it and transition.
Yeah, so I just to add, I mean, I think one of the things that we're going to see is we're going to see less and less of on-site data, and when this is going to transition, I'm not 100% sure, but we're going to see much more of raw data in the cloud with on-demand reconstructions, which would then allow you to reconstruct for clinical, it allowed you to reconstruct for quantitation or whatever else you wanted to do. So, the time for that in imaging is a little hard to say exactly when that's coming, but we already see that in radiation therapy, where a lot of these systems are cloud-based now, and we've seen issues with that actually, where people lose access and can't do imaging or can't do therapy because of cybersecurity issues and things like that. But I think data is moving in that direction, and imaging is moving towards that direction as well. So I think, again, down the road, this problem will probably be solved for us. It's more this interim of, when we're not there yet, what can we do to move things forward more efficiently and allow for, as you said, these various reconstructions for different purposes.
In the cardiovascular space, we've really taken a giant leap forward with the FFR CT that's done on coronary CTs to measure hemodynamic significance. That cannot be done locally. It's not, it's not a recon that sits on your scanner in your 3D lab. That goes out through the cloud to HeartFlow, and it comes back with a result. So there is a big leap of trust, and that trust is built on knowing that when you see certain abnormalities and what it means on those images, what it corresponds to a cardiac cath, and the workflows that have been developed and tested and FDA approvals for its use to reduce unnecessary diagnostic caths, enhance your interventional procedural suite, and get the right patients into the lab and not the wrong patients. So, but that has been in our specialty in cardiothoracic. That's the first big cloud-based recon where we have to entirely trust. We verify based on our clinical practice experience and on the large, the cardiology community, the large amount of data behind that technology.
Yeah, that example speaks a little bit to the data Chuck was presenting on endobronchial valves, and lung volume reduction. That I guess is a similar flow. I think people of the community there trust basically those cloud-based providers to provide the report. So there is, I want to bring up to the stage a question from Ben Lavon from the audience that I guess some of the elements had been already discussed regarding the problems of acquiring more data, but I think there is a very interesting comment or question around, we know that in the acquisition, there is params we cannot change unless you do another acquisition, you radiate again the patient, and there is params that we can change, like the reconstruction. So Ben's question is, what is the trade-off? What plays a big role with respect to visual reads and also quantitative analysis, those two kind of set of params? The ones we know we cannot change, and the ones we have some opportunity to change, by generating different kernels and so on. So what is the take of the panel? Because in providing to me a technical guidance, I guess that is the difficulty, that you have to have a lot of data on the things you won't be able to change. For example, dose. Once you set a dose profile, that is done, unless you want to do another scan. Any thoughts or?
One of the easiest things that you can't go back and change. So obviously you said, once you've set your dose, you've scanned, you're done, but is a slice thickness and the overlap of the reconstructions. That's a pretty basic level thing. Thin slices with overlapping reconstructions, because once you at least have that, if you need to do something with it, you're more likely to be able to do it than if you recon everything up to 5 millimeters and throw away all your raw data and you can never go back to it. So that's just one step in the direction of your acquisition protocol really matters, so that you can do other things with it later, even if you're not going to do it now. And you need to save that information. You can't, and I see this all the time from CTs that come into our center for multi-specialty consultation, is the lung images are all reconned at 5 millimeters, yet I know they've got this series of 2s that they did their coronals and sagittals on. So I know the data was there, but they didn't choose to reconstruct it in the basic images that you're using to look for the lung. So I think there's steps towards, more universal acquisition protocols that we could work on.
I think that is where also the role that AI was, the role of AI as Nick was presenting, like the super resolution, from lower resolution data, that is a topic that the AI community is pushing. The idea of using multiple kernels to then harmonize the data at a higher quality, with higher resolution profile. That is work being done by different groups from, my colleagues' lab and our lab as well. So I think, to me, I see a lot of value in really, even, in knowing, okay, some elements will be fixed and they will have to be overcome from the base, but then other elements I think can be overcome from the post-processing standpoint. And I know we have to be careful with these things, but I think slight thickness is one of the elements that I can see, AI, or at least these advanced computing tools overcoming if they are carefully validated. And I'm not saying, I'm not obviously advocating for doing recons at 5 millimeter, but I think we can definitely bring tools that will be able to put out the variability we see in the slide thickness across centers, to bring them on a plane, on an equal field or equal footing. So then algorithms can produce results on that equal footing, because I think now our biggest challenge is that if I use whatever software, I don't want to name any brand, in this center versus this center, you might get a little or some slight difference, just because obviously we went from the 1.5 we use here at the Brigham to the 1.2 you use at your institution. So, what is this where we are heading as well? I mean, Chuck, you from an industry perspective, is what you are pushing from the company standpoint? Is this the kind of
I don't know. I still think that it actually, I think it goes back to Ella's original point, and kind of what I tried to frame the overview talk about is like, what exactly are we trying to do? And what's the value? Because that's going to really set the stage for what the requirements are going to be. So for example, if we're going to just try to screen for COPD or something like that, we've seen a few papers come out that show that you can throw a bunch of different kind of recons in there and apply a deep neural net and get a pretty good job, like of just saying whether or not this person has COPD, or even their Fleischner emphysema score. Steve Humphrey's work was, I think, demonstrating that. But if we're trying to do, for example, longitudinal changes in lung density, we can't, I am not holding out hope on deep learning, like being able to harmonize a 5 millimeter reconstruction to 1 millimeter and be able to do a good job on something like that.
The real challenge here is harmonizing the radiologists. That's the bigger issue.
Yeah.
Well, so
and that would, in a certain sense, that would actually be easier, because they really could be, but they don't want to be.
well, so David, in following up on that, and also, Ella, you had been emphasizing the whole time about demonstrating the need. How much of this can be enacted based upon expert opinion, and how much of this actually requires clinical outcomes data to motivate, right? Because it's this is the surgical versus the medical mentality. Our surgeon will scream, and therefore it is agreed to be true. Whereas a medical physician, sort of ponders data forever until they finally find something.
I think about screening CTs, and I think about diagnostic CTs and the lens to which you come to them, right? In lung cancer screening, you're looking for early evidence of lung cancer. Number one, you're able to look for other things that can impact health. You can find emphysema, but the task isn't quantify my emphysema on that scan. The task is detect emphysema, and maybe to be able to say it's mild, it's moderate, severe, and what its distribution is, but not much more than that. So it's a detection task. It's not a task to treat and follow up that disease over time. If you're then going to take that same patient and say, now they're in a COPD program, there are therapeutics that you're going to apply, and you need to be able to follow something longitudinally over time, that can be a different scan type with a different set of parameters that are optimized for that. But coming into the screening lens doesn't mean you have to do everything that you can do in the diagnostic lens. So it's easy to think, well, we should just have one protocol that can do everything from everybody all the time. But that's not really the way patients come into the space of screening versus diagnosis. And just because we do see something doesn't mean that my pulmonary colleagues are going to have something that they can use to treat that patient right now. It may be a follow based on symptoms and spirometry, for example. So I think we have to be thoughtful about what are we really asking of the test that we're doing? Screening, detection, and then that might lead to diagnostics and management. That's different than coming into it as a COPD patient who's being evaluated for valves or emphysema surgery or clinical trials. So answering the question that's appropriate to the test, I think we have to be mindful of, and not saying we have to do it all with the same protocol all the time.
I just want to respond to George real briefly. You mentioned that we might need, these outcome information, which of course is a long time. But in between, we do have the ability to do, well, to look at it from a theoretical point of view, as well as do modeling and simulation, which I mentioned before for other things. And I would also add, there's a lot we can do with 3D printing and creating let's say, data sets that are 3D printed, that are sent around the world to various scanners. Again, we have this network now of lots of scanners who can easily scan something for us. So I would say we have a lot more tools at our disposal beyond doing a very expensive study, which ultimately we probably have to do anyway. But there's a lot more we can do before then.
I think
You know,
we have, oh, no,
I was just gonna
please,
say
Ella,
one more
go
thing.
ahead.
I think to get into the heads of radiologists, you have to look at where they get their information from. Sure, they get it through they get it through people they respect in the field, who they follow. They get it from education. They get their practice parameters from their professional society, right? That's where they look to and say, that's what the document says. Am I up to snuff? And hopefully they're actually looking. How can we start to change those things? Those people, there are lots of thoracic radiologists who are on those practice parameters for the different chest CT protocols. So it's hard to make sure we're including the conversation about quantitative outputs as those are going through iteration, and not just where they sit now, which is really in the diagnostic visual space.
And
Yeah.
we have two panelists that I want to add some thoughts, unless any of you have any pressing comment you want to make. I can open the stage for them. So Dr. Mulshine, your hand has been up for a while.
Yeah, thank you. It's a fascinating discussion. Glad you're having it. Ella, I've been very, very appreciative of your perspectives throughout, and I want to push back a little bit here, though, because in lung cancer screening, we have an NCD and it's going to happen, and we have 9 million, and then we're going to have 14 million people reviewed annually. And if you just think about it over the next 3 to 5 years, there's going to be considerable uptake and stuff like that. And so I think we should be thinking now about where the puck is going, not where the puck is now, right now. As I think, as you were starting to say, to use a hockey analogy. And I think that the reality is, if you screen 100 people for lung cancer, you'll find 1 lung cancer per year. If you screen 100 people for lung cancer, there's going to be 23, 24% that may have some element of emphysema. Additionally, might have interstitial fibrosis and whatever. And the cardiovascular study that was just done with coronary calcium from Sweden, they're gonna, over 50-year-olds, just general population, no tobacco or anything, 45% of them have some evidence of incipient coronary artery disease. So you're really going to be using this 3 to 5 years from now for this tobacco panel. And tobacco-related risk is very different than a full body CT scan, because of the Bayesian probability of disease, and not just some disease, but 3 of the 4 leading causes of death on the planet. And so from a statistical perspective, trying to understand that, yes, you're going to have to do something for coronary artery disease. Yes, you're going to have to do something for COPD. Yes, you're going to have to do something for lung cancer. And thinking about how to find the sweet spot in terms of harmonizing in such a way that it leaves open those possibilities is, I think, really the key question. And I think there's ways to do that. And I think that's going to happen is, if you choose wisely, your ability to look at progression of those diseases over a 10-year window and make a meaningful conclusion about the rate of progression of disease, the clinical aggressiveness, the need for any kind of targeted therapy that might be coming along, is going to be, it's going to be aligned. So you're going to be able to do not detection, but monitoring in a chronic basis, so that you'll be able to integrate with other clinical concerns of the population of primary care people, nurses, their primary care people, but taking care of this population relative to preventing premature death.
Thank you.
So there's a lot that you said there, Jim, and I think, the question still comes back is how well can you identify those changes? We're talking about diseases that are chronic. Many of them don't change that quickly. Emphysema tends not to change that quickly. We've been scanning patients for years with emphysema, and it is such a slowly progressing phenomenon, right? So
except for a subset that they're starting to identify in the study that we talked about earlier today.
Right, and in that subset, the question is, when are you detecting them at a point that requires intervention? Absent PFT abnormalities and clinical symptoms, what are you going to do for people? So we can detect things, we can measure change. Are you going to make changes based on quantitative imaging parameters in their diagnostics and in their therapeutic pathways without clinical manifestation of symptoms or disease in another way? So would you, we've got years and years of data on coronary calcium, right, that go way back toward, back into the EBT days about its rate of progression in serial studies and the Framingham study and everything. So we know a lot about coronary calcium already.
I don't think so. I don't think so. I've been looking at that literature, and because it's never been optimized for resolution, I think you lose a lot of the shades of gray that might be very clinically revealing. And you see the big clusters, but you don't see the granular detail because, it's still 3 millimeter slice thickness, and it's really not optimized for the evolution of some of the tools that you now have at your disposal. You know what I mean? And I take your point, but I think there's things happening that are going to give you ability to really, when did you start looking at 6 millimeter lung nodules in a serious way? It's not a very long history. And
so we have a 5-minute remaining, and I believe we have a question. Sean, I don't know, can we get Sean's?
Yeah, hi, I real quickly, I just wanted to inject the concept of repeatability into the discussion, partly because I'm coming from the Kiva perspective. And one of the things I wanted to say earlier to the question about, the standardization of the whole workflow chain from acquisition through reconstruction and analysis is to design an approach in which we set performance standards that are general in nature and require those performance standards to be met, but allow for multiple ways to meet them. And I still think that concept is extremely valuable because instead of just correcting for biases, it will enable us to both improve or reduce bias, but also improve precision. And I have to think, I guess, just from a conceptual point of view, that ultimately precision will be of value even for the screening domain. But this chicken and egg discussion that's going on, it's going to play into all of the ability to add additional features that are potentially clinically meaningful that we wouldn't detect otherwise, right? So I think we need to improve the acquisition side and harmonization side in order to get the data to refine and establish whether there's clinical value. That's all.
I want to respond to a comment that was in the chat, which is, if you do a screening CT up front and you detect something, does your next screening CT need to be, in a year from now, let's say, be of the same low dose protocol, or would you tweak your protocol because you also happen to see coronary calcium or you happen to see some emphysema? I mean, we're also under the assumption that you're going to do the same protocol. And I agree with you, Jim. I think you're very forward thinking, Jim Mulshine, about where we could be in the future. But do we always need to do the same protocol every year and somebody who comes back for screening if we've also identified there are other things there? Can we tweak the protocol and be more useful and provide better information? So it's great to think that everything all needs to be the same protocol. It makes it easy, one protocol all the time, done. But that might not be the right thing to do in subsequent screens. If you detected mild emphysema, maybe you should tweak your protocol a little bit. Maybe you can reconstruct it differently. I don't know the answers to the question.
So El,
That's
I
not
absolutely
fair.
agree with you. Just real quick, El. I think there's going to be a more refined diagnostic COPD analysis that brings in a lot of things with potentially looking at inspiration, expiration, and stuff like that, because we're going to be referring all these people to pulmonologists, and they're going to be getting spirometry, and they're going to say, no, I want a dynamic CT, or I want this, that, the other thing. So I think there is definitely a transition between screening and clinical management of a symptomatic disease or significant disease. I agree with you.
But as I was saying earlier, there is a lot of overlap. If you're trying to detect small calcifications, guess what? Resolution is going to make be a big part of that, as it is for small lung nodules.
So let's optimize where we can, and then agree to figure out what we need to figure out beyond that.
And I think that is, I want to make a remark on that direction. No, there are two elements. I think we are thinking a lot about, how can we define a combined protocol, but the reality is that many of the studies that Chuck has shown are based on the lung cancer screening protocol. And it's true there are limitations, but there is ways. He has been very effective in showing that there are ways to overcome those limitations. And also the second point is that main studies in the COPD world, probably to me, the biggest barrier we had in COPD was the issue, the dose, no, and the noise as a primary element that modifies densitometry. But now those primary studies are adopting low dose scans like lung cancer screening. And obviously, although it's a challenge, there is plenty of activity in the community to how those, how the dose can be somehow overcome through post processing, or even by readjusting, the threshold, or recalibrating the measurement, so to speak. And there is definitely plenty of statistical power or thinking going in this direction from the COPD gene group and other groups. So I guess something to consider is, are we as far as we think, or are we indeed much closer? And all we have to do is, fix some of the implementation issues more than the technical issues. No, I mean, are we truly dealing with a technical challenge here, or is an implementation challenge? No, I listened to you, Ella, and clearly I see the implementation piece of it big time. But I think the technical piece, aside of always, or personally, that my personal thought is, I always want more kernels, because it's fun, makes things so much fun. But I think really, besides adding a few more kernels that maybe can help us even empower some of the AI applications we were discussing, are we that far? I mean, I don't know.
Speaking of fun, we're at the end of our session.
Rick, but let them say yes or no, because at least otherwise I will have to wait one more year to get the answer. It will.
I think we're close. I think, if you can get 80% of the way there, that's good enough. The enemy of good is perfection.
All right. You get an extra point for making it brief. So we're at the 2:15, 2:16 mark here, and we've got a 15-minute break. Just on this past session, so as many of you know, I'm leading an effort to create this guidance document, this technical guidance document for a combined protocol. If you have any comments, concerns, questions about the effort, please email me. There is an ongoing activity, and it's just starting now. When we return at 2:50, no, what are we saying? At 2:30, we're gonna hear from the breakout groups, and I hope you enjoy your 15 minutes minus 3.